Okay, so in the first half of our lecture, we talked about some of the divisions of the nervous system, and we also talked about the little bit of physiology or um, the process of how our nerves communicate. So remember, really focus on trying to get down the whole concept of the action potential and how depolarization and repolarization function in the neuron. So just a reminder, our two major divisions are the central nervous system that consists of our brain and spinal cord, and the peripheral nervous system, which more or less contains everything outside of our brain and spinal cord. Okay, so this second half, we do a lot of anatomy. So some of that I'm more just going to walk you through, and make sure to take a look at your study guide or study outline and review activity, because that will help you focus in on what you actually need to know about the anatomy and different segments that we're going to go through within the brain. Because there's definitely some nice to know information thrown in here that you don't have to focus on for studying. All right, so we're going to start with the spinal cord. So our spinal cord extends all the way from the foramen magnum. Remember, our foramen magnum is going to be the opening at the inferior or bottom portion of our skull that allows the brainstem to exit. So our brainstem and spinal cord are continuous with one another. So it's not like our brainstem ends and then our spinal cord starts. It's just that foramen magnum is our dividing line. So you see we have a couple little letters here. We'll talk about those later. Kind of each individual nerve that's coming off of our spinal cord is named, but our spinal cord itself runs all the way from, like I said, continuous with the brainstem down to about the L2 or second lumbar vertebrae. So you see we end the spinal cord here at L2, but we have nerves that travel all the way down towards our sacrum and coccyx still. This portion of our spinal cord is termed the cauda equina, which means the horse's tail. Those nerves, if you actually were to pull the spinal cord out, kind of hang like the hair on a horse's tail. So that's how it got that name. And so our spinal nerves are going to serve all different parts of our body to allow movement and sensation. And so if we have damage to our spinal cord, we're going to have paralysis occur. And spinal cord damage comes in a wide variety of ways, because you can have a complete severance if you only have, say, the right half of your spinal cord, or only the posterior part of the spinal cord is damaged. It's going to determine what actual deficits are seen. And depending on what level it occurs at, that's going to make a big difference too. Because if I have something that happens up here in my neck, like say I have a full severance up here at C7 or C8, then everything below the chain is also going to be affected. Versus if I have something down here at the L5 or S1 level, it might only affect my foot. Okay, so gray matter and white matter. Remember we said our gray matter is going to be mostly cell bodies. Our white matter is going to have those myelinated fibers. And so in the spinal cord, our gray matter is right at the center. It sometimes is described like a letter H or a butterfly. You'll see the cross section of it here shortly. And then our white matter is that outer layer of the spinal cord. So that's where all of our myelinated fibers, or really myelinated axons, are contained. So our white matter is organized in what's known as columns, because they travel up and down the spinal cord. So think of that as the column. And so they're all located in the white matter. We have three different columns: dorsal, ventral, and lateral. We're not going to get into the specifics of what's contained in each of these areas. The only thing that I want you to be able to understand is the difference versus ascending and descending tracts. So we talked in the very beginning in part one about afferent information arriving. Ascending tracts carry afferent information that is going to arrive at the brain. So our ascending tracts are going to be axons that conduct action potentials toward the brain. So you can think of our ascending tracts as our sensory tracts. Vice versa, the descending tracts are going to go from the brains back down to the effector organ or tissue. So these are typically going to be some kind of a motor tract. So this descending tracts are going to go from the brain down. They're going to carry efferent information. Remember, efferent exits. And so that's going to mostly be our motor information. All right, our gray matter in the spinal cord, like we said, it has that H shape or butterfly shape, and we call the points of this horns. We have posterior horns. These are going to synapse with interneurons. So our posterior horns are going to primarily be sensory. Posterior is going to primarily be sensory. Our anterior or ventral horn is going to contain our somatic neurons. And remember, somatic is going to be our motor system to the skeletal muscle. So our anterior horn is our motor somatic neurons. The lateral horns contain mostly our autonomic neurons. So remember, autonomic sounds like automatic. That's a lot of our unconscious functions. And then we have a central canal, which is where we're going to have our cerebrospinal fluid traveling in the center of our spinal cord. So here's a cross section. So this would be like if we took the spinal cord and cut it so that we have a top half and a bottom half, and then look down on it. So here's that central canal. This is where the fluid is going to be located. And our gray matter is here in the middle. See that H or butterfly. So we have our horns on either side. And then we'll talk a little bit more about these as we travel out. So you'll notice here, one thing I want to point out before we go further is you have a dorsal root. So that dorsal root is going to come off this dorsal horn. Our dorsal root is going to be sensory. Our ventral root is coming off this ventral horn. And both of them turn into a spinal nerve. And we're going to talk about spinal nerves specifically, but you can see how our spinal nerve ends up with both sensory and motor information because it's a grouping or a combination of our two horns. Okay, we're not going to talk a lot about reflexes, but we're going to touch on it because it is an important concept in the nervous system. So it's an involuntary reaction. Of course, you don't think about doing a reflex, but it is transmitted through our somatic motor system and sensory system. So it's not an autonomic or an automatic nervous system responsibility. And so the idea behind reflexes is that it allows us to react really quickly to a stimulus, and it's going to be more quickly than is possible if we were actually thinking. So the example that I like to use is when you touch a hot surface with your hand. As soon as you touch a hot pan, hot stove, whatever it is, you just yank your hand away. If it wasn't a reflex, we would have to touch the hot stove, and then I have to think, oh man, that's hot. Oh man, that's really hot. Now I have to think about pulling my arm away. That takes a lot longer than if my reflex just does it for me. And so that's a protective mechanism. And so we're going to go through kind of the pathway of the reflex arc. So we'll go through it here with the words, and then we have a little bit of a diagram to walk through these 5 steps. You have your sensory receptor. So remember, that's where things start in general with the nervous system. We have to sense it first before our brain and spinal cord can interpret what to do with that information. So we have a sensory receptor. In our example, it would be a thermoreceptor, or one of our receptors that tracks temperature. So a thermoreceptor would say, this is too hot. That information is relayed to a sensory neuron. That sensory neuron relays its information to an interneuron. The motor neuron then gets its signal, and we pull our hand away. And sometimes some of our simplest reflex, we even skip this interneuron. So sometimes it's even as simple as 4 steps. So the sensory receptor in the dermis is going to feel the sensation first. It's going to pass its information to a sensory nerve. It's going to go into our dorsal horn. We have an interneuron neuron that's connecting our dorsal and ventral horn. Our ventral horn sends that signal out to the motor neuron and our effector organ, in this case, skeletal muscle. So remember we said with spinal nerves that these are going to arise from both our dorsal and ventral roots. So they're going to have both sensory and somatic motor neurons. And so remember, our vertebrae are each individual level at our spine, and the way they're stacked in between each vertebrae, there's what's known as a lateral foramen, where nerves are going to be able to exit. So each level has its own nerve. So they're named by the level that they emerge from. So as example, C for cervical, T for thoracic, L for lumbar, and the level. So for example, in your cervical spine, you have 8 pairs of cervical nerves, C1 through C8. You have 5 in your low back, you have L1 through L5. And so they're organized into what's known as plexuses or groups of nerves. So you do not need to memorize the levels that make up each plexus, but you should know that the cervical plexus innervates the muscles attached to the hyoid, the back of our necks and our heads, as well as the phrenic nerve. So for each plexus, just know the area that it serves rather than the actual levels that are considered that section of the plexus. Our brachial plexus, super important. So it's going to originate all the way from C5 to T1. And so that's going to supply our nerves to the upper limbs, shoulders, and hands. So pretty much our entire upper body is going to originate at the brachial plexus. Then we jump all the way down to the lumbosacral plexus, which is from L1 to S4, and this is going to supply our lower limbs. We kind of jump past thoracic because it has a different role. So you see, a plexus is just a grouping of nerves. We have our cervical plexus, our brachial plexus, our lumbosacral plexus. All right, we're going to touch on the concept of dermatomes real quick. So the nerves arising from each section of our spinal cord are going to supply a specific region of our body. So a dermatome, remember derm means skin. A dermatome is going to be an area of the skin that gets its sensory innervation. So it's the nerve for sensation in that area is by a specific pair of spinal nerves. And so C1 we skip, but all of our other nerves have a specific cutaneous or skin sensation distribution. So it'll make sense when you see this picture here. So this is what's called a dermatomal map. And you see we have little sections that correspond with each nerve level. So let's say, for example, I had damage at my C5 nerve on that right side. If I lightly brush that area of an arm, it's going to have either no or decreased sensation because it is supplied by the C5 spinal nerve. So as a clinician, this is something that we would use quite often with our neck and low back pain patients. If they were having numbness in an area, if they were having pain in an area, if they were having decreased sensation in an area, that as a physical therapist can tell me where I might need to investigate or what level may be causing some of their issues. All right, moving on to the brain. So these are our 4 major regions of the brain. We have our brainstem, our cerebellum, our diencephalon, and our cerebrum. We'll go through each of these. Okay, our brainstem is made up of 3 components. So we have our midbrain here, our pons here, and our medulla oblongata here. And so just to orient you guys, a lot of these brain slices show just one half of the brain. So if we cut longitudinally, so we get right and left halves, a sagittal plane cut, then we can see inside one half of the brain. So we're looking inside of the brain. So our medulla, like we said, our brainstem is continuous with the spinal cord, and our brainstem as a whole is extremely important because it regulates a lot of our life functions. So that includes things like heart rate, blood vessel diameter, our breathing, our swallowing, vomiting, hiccuping, all these down here. So our medulla contains a lot of our life centers. It also has some areas that are known as pyramids, which are part of our ascending tracts and descending tracts. And so part of that passes through the medulla. The pons helps the medulla with some of our life center activities. So breathing, chewing, salivation, swallowing, kind of all that stuff that we're not necessarily thinking about doing, but keep us alive and functioning. Another important portion of the pons is a relay station between the cerebrum and the cerebellum, and we'll talk about both of those parts here soon. Our midbrain is the most superior portion of our brainstem. It helps with eye movement, as well as pupil function. It has components that trigger us to turn our head towards noise, and it's very visual and auditory. So visual and auditory reflexes, and that's about all the midbrain does. It doesn't have as many of those life centers as the first two components of our brainstem. So our reticular formation, you don't really need to know this part. It's in multiple areas of the brainstem, but it's very much involved in our circadian rhythm or our sleep-wake cycle, as well as just kind of being able to be aroused and maintain consciousness. All right, our cerebellum, sometimes this is called the little brain. And so its main job is to control balance, muscle tone, and our fine motor function. So if you encounter someone that has cerebellar damage, oftentimes they're walking like super uncoordinated. So like if you've ever seen a baby giraffe walk, they're super clumsy, or a baby horse, or even think of Frankenstein walking. They can make it happen. It just looks really uncoordinated and odd. So here's our cerebellum here. So they call it the little brain because it kind of sticks on the back of the brain. The next thing we're going to talk about is the diencephalon. And so it shows here that we have three different components to it: the thalamus, hypothalamus, and the epithalamus. But typically you will just see this listed as the thalamus and hypothalamus. We're going to kind of ignore the epithalamus. That's a little bit too specific for what we need. Okay, so our thalamus is the largest part of the diencephalon, and its job is to regulate sensory input coming in. So it's trying to help us make sense or sift through some of our sensory information to determine what is relevant. And it has a large influence on our mood, and it also has a large role in detection and interpretation of pain. So the only thing that I'm going to highlight within the epithalamus is this pineal gland. So our pineal gland we'll talk about in the endocrine chapter in chapter 10, but it plays a large role in controlling some of our cycles that are influenced by light, dark, or circadian rhythm. So our pineal gland secretes melatonin, and so that hormone is what is intended to make us sleepy. So I'm sure you've heard of people that take over-the-counter melatonin in an effort to help them sleep. The hypothalamus, we're going to talk about a lot in chapter 10, or has a big role in our endocrine system because it controls our pituitary gland. So it's going to have a large role in helping us maintain homeostasis. And it also is another structure that is going to influence our emotions and even emotions related to sexual attraction and desire. Okay, our cerebrum is the largest part of the brain by far. And so we divide it in a few different ways. So we have a right and a left side of our brain. That's separated by the longitudinal fissure. You'll be able to see that a little better when we look at an above view. And we have 4 lobes, and these you definitely need to know. Our frontal lobe, so just to orient you guys, we're anterior, posterior. So frontal lobe, our central sulcus separates the frontal lobe from the parietal lobe. Our lateral fissure separates our parietal lobe and temporal lobes. And then we have our occipital lobe on the back. And then don't forget the cerebellum is tucked underneath. So the cerebellum is its own structure. It is not considered part of the cerebrum. So here's our top-down view. So we have the longitudinal fissure is dead center. That's going to give us our rights and our lefts. I want to point out sulci and gyri. So your sulci or a sulcus is going to be one of those depressions. A gyri or gyrus is going to be the ridge. And if we have a really deep sulcus, we call that a fissure. All right, so the cerebral cortex is considered the surface of our cerebrum, and it's kind of opposite of the spinal cord in the fact that our gray matter is on the outside and our white matter is located on the interior. So remember with our spinal cord, we had that H or butterfly of gray matter in the center and our white matter on the outside. We're going to flip-flop. We don't have that H or butterfly pattern, but we do have our gray matter all on the outer portion of our brain. And so our cerebral cortex is going to do a majority of our thinking and communicating. And it also has a role in initiating and remembering voluntary movements. So we already talked about that longitudinal fissure that divides into right and left. The gyri is our folds or our ridges, our sulci are indentations, and our fissures are our really deep indentations. So our right and left hemispheres are responsible for different aspects. So you may have heard people say before that they're either right-brained or left-brained. So this is what they mean by that. Our brains control the opposite half of the body. So the left hemisphere controls the right side. The right hemisphere controls the left side. And then our left hemisphere, we see higher activity there when we're doing things like math, analytics, statistics, speech is also contained over on that left half. And then the right hemisphere is known for more of the artsy kind of creative side of things, like music, art, other abstract kind of imagination, creative ideas. And then we have our corpus callosum, which is the connection between the two hemispheres. So if I went back up to this picture, our corpus callosum would be right in this center to connect the two halves. Okay, so our corpus callosum, that's a lot of axons that connect our two halves. Okay, now we're going to get into the lobes of the brain. So I don't need you to memorize these function sentences, but I do need you to know the big picture of what each lobe is responsible for. And we can pretty much get that down to one word each. So once we go through all of them, we'll kind of summarize. So we said our frontal lobe is in the front, it's anterior. And its main job is going to be motor functions. So there is some personality and impulse control located here, but definitely most often or most important is the motor function. Parietal lobe, vice versa, is going to be mostly our sensory input, such as touch, pain, pressure, temperature, taste, really any whether it's general or a special sense, it's going to end up going through our parietal lobe for interpretation. Our occipital lobe is in charge of vision. Remember, that's all the way on the back half. Then our temporal lobes, kind of just above the ears, inferior to the parietal lobes, they're going to be in charge of hearing, smell, and memory. So frontal lobe, you should always think motor. If you can just remember motor and frontal go together, that is good enough. Parietal lobe, think sensation. Occipital lobe, think vision. And temporal lobe, I want you to kind of think of our other senses. So our central nervous system is constantly receiving sensory input. Our sensory receptors are programmed to detect. They're not programmed to interpret. They're not programmed to ignore unimportant things. Their job is just to get the information and send it up. So our central nervous system is the one that's actually in charge of filtering through that information and deciding what is actually important and what is not. So most of the sensory input that we bring in, we're actually unaware of, and it would drive you nuts if you had to actually think or consciously pay attention to every little piece of sensory input you were getting. So here's another reminder that our somatic motor system is what's going to innervate our skeletal muscles. And so this is going to help us maintain posture and balance, even when we're not thinking about actively doing a movement. We always have some sort of muscle tone that is maintained. Of course, it's going to help us move our trunk, head, limbs, tongue, eyes, pretty much everything that's voluntary. And then remember, communication is an important function of our motor system and muscles, because our facial muscles, expression, speech, they are what are allowing us to do that. So we went over the big divisions, or the lobes. We're going to touch on just a couple of specific areas within the brain. We'll start off with our primary motor cortex. Based on what we talked about, it shouldn't be a surprise that that is located in the frontal lobe, and it's going to control our voluntary movement. So any voluntary movement is going to be controlled by the primary motor cortex. Our premotor area and our prefrontal area are both in the frontal lobe as well. And so this is where we actually organize our actions. So our premotor area, in a sense, almost kind of organizes and writes the instructions for a movement. And then when we actually carry it out, that's done by the primary motor cortex. And the prefrontal area helps that premotor area with planning ahead and having a bit of foresight to know what is going to happen or what we need to do next. So here is that primary motor area. And we have our premotor area lays just in front of it. And then we have our prefrontal area up here. So all of that is part of the frontal lobe. If you go back to our parietal lobes, we have our primary somatosensory cortex. And we have a somatosensory association area, which is similar to our premotor and prefrontal areas that we just talked about, but for the sensory side of things. So we said our occipital lobe is associated with vision. So we have our visual cortex back there. And then a couple other things that I wanted to point out. We have our auditory cortex, or auditory area, in the temporal lobe. And then we have a couple different areas that are dedicated to speech. So we have a sensory speech area that's concerned with kind of interpretation and understanding of speech. We have a motor speech area that is involved in actually creating speech, or making our muscles kind of make the movements to make certain sounds and words. So we just said we have a sensory and a motor area. Our sensory area is known as Wernicke's area. That's in our parietal lobe. Like I said, that is concerned with how we actually hear the words and how we comprehend them. And then we have our motor area, which is called Broca's area, and that's where our words are formulated. So you may not have heard this term, but if you ever heard the term aphasia, that means difficulty or absence of speech. So you can have sensory or Wernicke's aphasia, or Broca's or motor aphasia. So if you're curious, if you Google these in look up some YouTube videos, it's very interesting to see the difference between someone affected by Wernicke's area versus Broca's area. So with someone with Wernicke's aphasia, they're speaking very normally, they're putting sentences together, it sounds like it's flowing very nicely, but it just doesn't make sense. It's just nonsense, more or less. The words don't go together. The way to remember that Broca's area is your motor area is that their speech is broken. So broca. So they have a really hard time actually forming their words. And that can be super frustrating on either sense, but especially with Broca's, they really can still understand and comprehend how to put language together. Their mouths just don't want to make the words. They just are having a hard time coordinating the movement. All right, we are going to touch on brain waves and consciousness very briefly. This is not something that you will really be tested on, so don't spend too much time studying this. So an electroencephalogram, an EEG, is how we are going to record the brain's electrical activity. So we already talked about how our nervous system is basically like the wiring of our body. It's communicating via changes in polarization or charge and more or less electrical impulses. So if we put electrodes on our scalp, we can record that electrical activity. And so they've researched enough to know that we have different kinds of waves or different shapes to that electrical activity that coincide with what is going on in the body. So alpha waves, that's when we're in an awake but resting state. Beta waves are when you're really working. So if they were doing an EEG on me right now, I wouldn't necessarily call this intense mental activity, but you would be able to see that there's a little more going on than me sitting still. Delta waves we find only in deep sleep. It's thought that our brain waves, and especially those deep sleep delta waves, are somehow responsible for helping to cleanse and kind of refresh our brain. And then theta waves we find only in children. So here's just an example or an illustration that shows how they determine differences in those waves. So this is an EEG setup in an office. All right, one of the last concepts that we're going to touch on is memory. And so we have a few different types of memory. So working memory is when our brain is going to briefly store the information for performance of a task. So we're only going to keep that memory around long enough to let us perform that task. So it's only going to last a few seconds to a few minutes. So this is like when you look up, and now that we have all our smartphones, not as important, but say you look at a telephone number that you need to call, you memorize the number real quick, you dial it, and then you're probably not going to remember that number anymore. That's working memory. Short-term memory is going to be a few minutes to a few days. And so we utilize short-term memory, obviously to remember what kind of just happened to us somewhat, but also we use that to transfer and consolidate long-term memories. So if a short-term memory has enough relevance or importance, or if it's one that continues to pop up, it becomes a long-term memory. And in a sense, the more emotional connection you have to a memory, or the more often you think about it, or the more often you experience similar things, the more it's going to become permanent. And that process is called consolidation. So in a sense, every time you think of a long-term memory, that's firing off specific neurons that are associated with that memory. And so as we continue to use them, it's going to continue to strengthen its connections in those neurons. So it's like a use it or lose it kind of thing. The more you use it, the stronger that connection and memory becomes. All right, our limbic system is our emotional system. And so it's connected with a few of our sensory systems as well. So one of the strongest connections is with our olfactory complex or our olfactory system, our sense of smell. And there's some deep regions within the cerebrum and diencephalon, like the thalamus, where we interpret emotion as well, that are all grouped into the limbic system. So our limbic system is going to influence how we view a memory, kind of whether that's a positive, negative, the emotions associated with a memory, our emotions, kind of continuous emotional state, our visceral responses to emotions, which is your organ. So like when you feel like, say like my heart hurts, after something bad happens. That is driven by the limbic system. So sometimes it's used as kind of like a saying, but there is some truth to it. Motivation, of course, is associated with emotions and mood itself. So we said a major source of sensory input to our limbic system is the olfactory nerves. And then we already mentioned it's associated with both the thalamus and hypothalamus in the diencephalon. All right, our meninges. So these are another one that you guys definitely need to know. So we have 3 different layers of tissue that are going to surround both the brain and the spinal cord. So our most superficial, or the outermost layer, is the dura mater. So think dura, durable. It's going to be the toughest of our 3 meninges. Our second meningeal layer is very thin. It's our arachnoid mater. So we have space between the dural or dura mater and arachnoid mater. That becomes the subdural space, and usually a very small amount of what's known as serous fluid. So not cerebrospinal fluid, but serous fluid is in between our arachnoid and dura mater. We then have the pia mater. That's kind of directly on the surface of the brain and spinal cord, not easy to separate. And between our arachnoid mater and pia mater is where our subarachnoid space is located. And this is where we actually have our cerebrospinal fluid, and our blood vessels run within this layer as well. The cerebrospinal fluid is what bathes our brain and spinal cord, and it gives not just hydration and nutrients to it, but it actually provides protection. So think about throwing a ball in the air, kind of at a wall, versus throwing a ball underwater, how much slower and how much less power you're going to be able to get on it. So that's why, part of the reason why our CSF is there. So remember back from the beginning of our chapter when we talked about the glial cells, we have ependymal cells in our choroid plexuses. So you don't really need to know much other than the choroid plexuses are where cerebrospinal fluid is produced by the ependymal cells. And so we'll go through this pathway real quick. So we have choroid plexuses here in our third ventricle. So ventricles are just openings in the brain where this fluid is going to pass. So we make the fluid itself from the choroid plexuses, and then it's going to travel through this kind of labyrinth system of ventricles and then travel down and around. So it basically goes from the brain all around down into the spinal cord, back up around the brain, through, and eventually it'll drain out to be recycled. You do not need to know this flow. You should know that the ventricles and the choroid plexus is where our spinal fluid originates. All right, very last one is cranial nerves. So you don't need to memorize all of them. I'll highlight a couple of major ones, and they're named by Roman numeral. So that's not, they're numbered 1 through 12, but you'll never see a normal kind of Arabic number 1, 2, 3. It's always going to be a Roman numeral. And it's also good to point out we have some that are just sensory, some that are just motor, and some that do both. So the first few, or first 3 really, are easy to remember because they're named for what they do. Cranial nerve 1 is our olfactory nerve, and that's purely going to be smell. All it does is smell. Again, optic nerve is another pure sensation one, and it's going to just transmit our vision, visual information. Our oculomotor nerve is a motor-only nerve. So oculo, the eye, motor. So it's one of our nerves that controls our muscles that move our eye. Trochlear nerve is another motor movement specific to the eye. The trigeminal nerve is a super important one for our function because it's both motor and sensory. So it does a lot of pain and other sensory information for our eyes, our lower and upper jaw. And it also is the motor input for all of our muscles of mastication or our muscles that allow us to chew. So without the trigeminal nerve, we're going to have a hard time feeling anything on our face, and we're going to have a hard time chewing. Cranial nerve 6 is the abducens. This is another one that's purely motor for our eye movements. The facial nerve is the nerve that supplies a lot of sensation throughout the face, as well as the motor innervation for a majority of our facial muscles for facial expression. The vestibulocochlear nerve, I will mention this again in our next chapter on the senses. This is going to be purely sensory. So there's two halves to this nerve. You have your vestibular half, which is going to be our equilibrium and balance. And we have our cochlear half, which is going to be your half that's purely for hearing. So balance and equilibrium and hearing with the vestibular cochlear nerve. That's one you should probably know. Number 9 is glossopharyngeal, in both motor and sensory. So glosso means tongue, pharyngeal means pharynx. And so that's the back of our throat. So you can think it is there for taste on the tongue and the motor aspect for our muscles that allow us to swallow. Number 10 is the vagus nerve. This one is motory and sensory as well. And even though it's located as a cranial nerve, it actually goes all the way down to our organs in the thoracic and abdominal cavities. So that one's a little bit of an odd one. And then last but not least, we have 11 and 12. So 11 is called the accessory nerve. It's a motor one. It helps us shrug our shoulders up. It helps us bring our chin to our chest, turn our heads. So a couple muscles that are in our lower part of our neck. And then last but not least, we have the hypoglossal nerve. And this is the nerve that allows us to move our tongue. So they test this one by having someone stick out their tongue. If it only wants to go to one side or the other, they know that they have damage at the hypoglossal nerve on the other side. And this just kind of shows how our cranial nerves are distributed throughout the brain. So you see they kind of go from anterior to posterior, and they travel down the brainstem as well. You certainly do not need to know locations for any of that. All right, very last couple, our autonomic nervous system. So we mentioned a couple times, autonomic sounds like automatic. So remember, this is going to be all of our involuntary stuff. So that includes smooth muscle, cardiac muscle, and glands. And so this is mostly going to be unconscious. We don't think or choose to make our autonomic nervous system work. So the only thing that I really need you guys to understand with the autonomic nervous system, besides the involuntary aspect, is our two major divisions. So we have our sympathetic division and our parasympathetic division. So our sympathetic division is going to increase activity. More or less, it's going to prepare us for physical activity. So we call sympathetic division as our fight or flight division. We're either going to fight or flee. Either way, we need to be ready to go. Our parasympathetic is the opposite. So we say the parasympathetic division is the rest and digest division. So it's going to activate stuff like digestion, our urinary and excretion systems, and overall kind of tone the body down. So sympathetic is fight or flight, parasympathetic is rest and digest. So in general, sympathetic is going to turn everything up except for digestion, and our excretion systems are going to be turned down. You don't want to have to digest food or go to the bathroom when you're running away from something. And then parasympathetic is going to be rest and digest. So this, I'm just going to highlight real quick, kind of shows you why we ignored our thoracic section when we were talking about the plexuses earlier. So our sympathetic division is going to be organized into these groups of ganglion that originate off of our T1 through L2 levels. So you don't need to kind of memorize this or pay attention to this too much. It just kind of shows you how it gets down to the different organs. You need to remember sympathetic is fight or flight. Parasympathetic is going to be rest and digest. All right, that wraps up chapter 8. So, like I said, that is definitely the biggest chunk out of unit 3. So, this is where you should focus a majority of your time. Chapters 9 and 10 are also a part of unit 3. So, we'll get to those here shortly.